Kanchi Kamakoti Child's Trust Hospital is a leading pediatric tertiary care hospital located in the heart of Chennai. Hospital is facilitated with 200 beds and has been serving as a successful tertiary care referral center. We provide world-class healthcare in the field of general pediatrics, pediatric surgery, neonatology, and allied specialties. Our hospital is a center of academic excellence as we conduct Diplomate of National Board and Fellowship Program courses in pediatrics. Several of our doctors have been honored with gold medal and other laurels each year. Our hospital is accredited by full NABH, laboratory is accredited by NABL, and our nursing department is certified by NABH Nursing Excellence. At the emergency department, we care for children aged 1 month to 18 years. Our anesthetists are specialized in the care of children of all ages, from newborn to teenagers during surgery. Our operating rooms are equipped with the most advanced anesthesia machines and monitoring facilities, exclusively designed for children's surgery of all age groups. Pediatric surgical department was started in the hospital by the founder, Professor Dr. M.S. Ramakrishnan, who was a pioneer in the field of pediatric surgery. Over 7,000 surgeries are being done every year by the renowned surgeons. Pediatric Intensive Care Unit, started in 1991, was the first separate PICU in the private sector in Chennai. PICU managed by senior intensivists, our hospital has a level 3 neonatal intensive care unit which caters to nearly 1,000 high-risk newborns every year. NICU is managed by a team of dedicated neonatologists with a survival of more than 95% among all admitted neonates, which includes newborns up to 450 grams birth weight. Our hospital laboratory is accredited by NABL. We maintain accuracy and speed with well-trained and experienced technicians. Radiology department is equipped with digital radiography technology and advanced ultrasound machine. Child's Trust Medical Research Foundation conducts extensive research in the field of pediatrics and allied disciplines, including basic clinical research. Kanchi Kamakoti Child's Trust Hospital was awarded World's Best Hospitals by Newsweek consecutively for last 2 years. We received Best Pediatric Hospital by TanCare and FICCI. We also received Best Teaching Hospital and Nursing Excellence Award by Association of Healthcare Providers India. We were also awarded Best Childcare Hospital Award by News 7 Tamil Channel. We know kids because we treat kids. Thank you.
Good evening, everybody, and welcome to this edition of the Hindu Wellness Series presented by Kanchi Kamakoti Child's Trust Hospital in Chennai. The topic for today's discussion is safe surgery and anesthesia for children. And we have an interesting panel of 3 doctors, an anesthetist who prepares children before the surgery, a pediatric surgeon who performs surgeries on children, and a neonatologist who takes care of the baby post-care. It is the combination of their understanding and their efforts that our children come out safe and sound from any surgical interventions. The very thought of a surgery can be distressing to parents and kids alike. And the idea of your child undergoing anesthesia can be even a more cause of concern for everybody, especially the families. But then situations do arise when even small babies and young children need anesthesia to be able to tolerate various kinds of tests, the surgeries performed on them, and several other invasive procedures. Obviously, parents are the most worried lot with lots of doubts and questions about anesthesia, surgery, and the safety of their children. To explain all this in detail, we have with us today Dr. S. Ramesh, Senior Consultant and Head, Pediatric Anesthesia, Dr. N. Chandrakumar, Senior Consultant and Head, Neonatology, and Dr. Priya Ramachandran, Senior Consultant and Head, Pediatric Surgery. Working with Kanchi Kamakoti Child's Trust Hospital, the three doctors will give us brief presentations about the work they do. And at the end of it, the participants are requested to direct their questions to any specific doctor they wish to once the QA box is open for them. So let us start the session. And I would like to invite first Dr. Priya Ramachandran, who trained as pediatric surgeon in Children's National Medical Center, Washington, D.C. She is the daughter of the founder trustee of the Kanchi Kamakoti Hospital. Dr. Priya's main interest is in liver surgery, childhood cancer surgery, and urology. She is also the founder trustee of the Ray of Light Foundation, providing free treatment of unaffordable children with cancer. She will tell us about the most common surgeries done in children and address the parental concerns while talking about the concept of daycare surgery. So over to you, Dr. Priya.
Thank you. I'd like to thank the Hindu Wellness Series and Kanchi Kamakoti Child's Trust Hospital, where I have been working for the last 22 years, for giving me this opportunity. And I'd like to begin by saying that a surgeon's responsibility goes beyond the operation itself. The physician treats patients by prescribing medicines. So the physician is responsible for the treatment of the patient, but it's a shared responsibility. The medicines also have a role to play in treating the patient. As far as surgery is concerned, the responsibility of making the patient better rests exclusively in the surgeon's hands. If the physician treats the patient and something goes wrong, the blame is shared between the physician and the disease, and sometimes the side effects of the medicines are thought to be responsible. But when a surgeon treats a patient and does not make the patient better, does not cure the patient, the responsibility for that rests exclusively in the surgeon's hands. What I'm trying to say is the ball ends in the surgeon's court. So it's very important for surgeons to realize that. And especially, this is even more nuanced for a pediatric surgeon. I can put my life in anybody's hands. I'm an adult. I can make that decision, and I can give myself up to a doctor whom I think is fit to treat me. I will live with those consequences. When it is my child, if I have to put my child's life in somebody else's hands, that's a huge burden. And for that parent to trust the doctor and give the responsibility of his most precious possession to that doctor, that's a big ask. Under those circumstances, the pediatric surgeon has to reassure the parent that their child is safe in the surgeon's hands. And we often tell them that we will consider their children as if they were our own. Children are the most vulnerable members of the society, but children who need pediatric surgery are even more vulnerable. In fact, they are at their most vulnerable, as you will see in this talk that I'm about to give. The children we deal with as pediatric surgeons have illnesses pertaining to all the major organ systems of the body. My special interest, as was mentioned, is liver surgery. And I'll begin with showing you a patient who recently underwent liver surgery. We'll just share the screen in a minute. Yeah. So just give me a minute. Next. This is a little baby who was 2 months old and needed liver surgery urgently because he had a condition called biliary atresia. The bile ducts in his liver were blocked and he was not able to drain the bile, and hence he was jaundiced. When we talk to these parents and ask them to trust us with their child, as you can see, they have to come up with a lot of trusting because this child is small, this child is seriously ill. And under these circumstances, what we try to tell them is the hard, cold facts. The child will not improve without surgery. And then we tell them about our experience as far as this particular disease is concerned. We have an extensive experience. We've done more than 110 operations for children with this condition. And when we give them the facts, parents are often convinced to let us do this surgery. Next. And this surgery, as you can see, in a small baby is very, very extensive, where we make sure that the liver drains bile completely. That's the baby liver. And the surgery is done with the baby's liver outside the body, partly outside the body. And it requires a lot of finesse. It requires a lot of dexterity, and it requires a lot of patience, and it takes a lot of time because the stakes are high. If this surgery succeeds, the child will not need a liver transplant. If the surgery does not succeed, the child will need a liver transplant, and the transplant itself is a major surgery followed by a long course of immunosuppression. If the surgery succeeds, the child will grow up to be a normal adult, just like any one of us. So with the stakes being so high, we tell the parents that this is our experience, this is what we can offer your baby, and usually this is enough for them to get us to trust them. Now there's a risk in this operation, a risk that happens during surgery, which we almost never encounter because our hospital is expert at performing safe surgeries. And there's a risk that the operation may not succeed. In about 50% of children, the operation may not succeed. But if you have counseled the parents adequately before, they are able to accept that and live with the consequences, because by then you have earned their trust. So being a good surgeon a good pediatric surgeon is all about earning the trust of the parent. We also do surgery for diseases of the lung. As you can see, the picture shows a diseased portion of the lung, which we had to remove in a 2-year-old child. It's a brief video showing that. And I'm holding the diseased lung in my hand, and this child is 2 years old, and there's hardly any space to operate. And we've got, 4 hands trying to get into a tiny chest. Here again, the surgeon is faced with the responsibility of operating on a major organ and of bringing the child out of surgery and ensuring that the child lives an entirely normal life. Like I said, the stakes are usually very, very high in pediatric surgery because most diseases have a published morbidity of almost 0 and a mortality of almost 0. So the responsibility is there on every pediatric surgeon to maintain the morbidity and mortality at close to 0, which means all our patients have to pretty much survive. Next. This is a child with a tumor in the ovary. We do a lot of cancer surgery, and this is a completely different ballgame. Here, the surgeon plays a secondary role to the disease. The surgeon's role is to remove the tumor, and the surgeon's role is to make sure that the child gets treatment, chemotherapy before and after the surgery, but the actual chemotherapy is done by oncologists. Here again, the surgeon has to be a full-time counselor for the parents, because we are usually the ones who make the diagnosis of this tumor. They come to us with a big tummy, and then you feel the tummy and you find a tumor like this. And we have to break the bad news that this is cancer. Now, an adult will accept that diagnosis. They may feel it's a death knell, but they will accept it. They will come to terms with it. But for a parent to come to terms with that for their child is extremely difficult. And here again, we have to play counselor and reassure them and tell them that we will do our best. We can never promise cure. With cancer, we can never promise cure, which we can with other diseases. With cancer, we always tell them that we will do our best, and looking them straight in the eye and telling them that usually gets them to trust us. Now, this is a child with a tumor of the kidney, and we encounter this frequently, and I'm very proud to say that the way these surgeries are conducted in our hospital, they are merely incidents, they are not events. They just happen in the course of a regular working day. In places, children have to be treated in places where it is safe for them. Children are not little adults. If I had appendicitis, I will not go to an adult doctor. I'm sure you won't either. So why should a child come to an adult doctor for appendicitis, for any other disease? A child should be taken to a children's specialist, should be taken to a children's center. And if you take this child to an adult center, they will treat the child like a little adult and make a big deal out of an operation, which is really simple and easy to perform in a pediatric center where you have the support structures, which we are going to talk about shortly. Now, again, for cancer surgery, leukemia is the commonest cancer that we encounter in children. And for that, we do this operation called a chemo port insertion. We do a lot of these surgeries. I'm not sure of the exact number, where we put a tube into a vein in the neck, and that tube goes straight into the heart of the baby. And the tube has a hub through which you inject the chemotherapy. And this tube can stay inside the baby for almost 2 to 2.5 years. And here again, the reason this is not a difficult operation to do, it takes about 20 minutes. The reason I showed you the slide is, here again, the surgeon is the counselor, because the parent of a child with leukemia is usually in shock. Because they have just been told by the oncologist about the survival possibilities, survival chances, percentages. You cannot put a number on a child's life. You cannot say that this child has a 60% probability of survival. That's a death knell to the parent, I'm sorry. So these parents usually come to us after having been counseled by an oncologist. And although this is a simple procedure, we need to do a lot of talking to tell them how we are going to do this operation. Again, the parents kind of turn to us and ask us the same question: will my child survive? And here again, it is best to be honest and tell them, I don't know. I'm not an oncologist. I'm a surgeon. I will do my best for you. And the rest is up to the oncologist and God. I find the last 22 years that I've been practicing pediatric surgery in India, I have found that to be honest with parents is the best way to get them to trust you. Now, this is another operation which we do very often in children. It's an operation which is done. It's actually a cosmetic and functional operation where we have to bring the hole to the tip of the phallus so that the child can pass urine like a boy. Next. It's a major operation, and it involves, it takes a few hours to do. And here again, the parent is trusting you with his son's manhood. And it's a big responsibility for us to ensure that the operation goes well, the child does well, and most of all, the result should be cosmetically and functionally perfect. Now, we have a series of patients on whom in the newborn unit on whom we are asked to operate. These are babies born with congenital defects. This is one such baby. And as you can see, the baby is born without a hole to pass motion. So there is no anus. He has no anus. And what we've done is we have created a hole in his intestine to bring the motion out, to tide him through the newborn period. And when he grows up, we will do the definitive operation to bring the hole to the right position, which is where the anus ought to be. Now, I'm going to spend a little bit of time talking about daycare surgery because this is the commonest thing that's commonest surgery that we do. Now, daycare surgery, the stakes are probably the highest because the disease is often something that is not going to kill the patient. The disease is something that is going to cause the patient grief. And here you have to operate and put the patient through an experience which feels a little bit like dying. It's difficult to justify this for a simple disease. For instance, this is a child who was born with the testis up in the groin, and we had to bring it down into the scrotum. The operation takes about 30 to 40 minutes. And in our center, because we have experienced pediatric anesthesiologists things go really smoothly, but things can go wrong in very quickly in this operation in an adult hospital, both with the anesthesia, which I'll let Dr. Ramesh talk to you about that, and with the surgery as well, because you have in your hands the vas, the spermatic cord of this very young child, and the surgeon has to be technically adept at ensuring that the spermatic cord is not injured at any point. And the parents have to understand that the stakes are highest in daycare surgery. And this is where they actually need a specialist tertiary care children's hospital. Because for the other major diseases I showed you, usually they will be referred to a tertiary care hospital by the adult physicians who might see them, etc. But these kind of daycare surgeries, most adult hospitals think they can handle it, but this is where they actually need the support of a tertiary care hospital, because here, these protocols, the way the surgery is done, the way the patient comes in and goes out and recovers, the protocols are all so standardized for children that it works perfectly in a tertiary care center. This again is the commonest daycare surgery we do. This is a hernia operation. I'm holding up the hernia sac. Now the hernia operation again is a simple operation which will take about 15 to 20 minutes to perform. That's it. But this can become a big deal if it is not done by experienced hands. And we have known major complications. We've seen patients who have come to us who have been operated elsewhere with major complications for something as simple as a hernia. Now, I like to tell my students, we have trainees who come to us to train in pediatric surgery, that there is no such thing as a simple operation in a child. In a child, every operation is a complex operation because you have not obtained the child's consent to play with his life. That consent has been given to you by his parent. So you are in proxy, he has given you consent, he has not directly given you consent, and you are now going to perform an operation on him. You have to take it extremely seriously, much more seriously than you would if the patient directly given consent. So this is the hernia operation. And this again is a newborn who was born with with part of the intestines outside the abdomen. And we did this operation to get the intestines back in. And this again is a newborn with a hole in the diaphragm. So you can see his lung from inside the abdomen, which you should not be able to see that. And here the entire diaphragm needs to be repaired. And like tumor surgery, newborn surgery is a collective responsibility. Newborn surgery, the responsibility rests with the surgeon as well as the neonatologist, especially in a condition like this, where after surgery is done, taking care of that lung, which was in contact with the intestine for ever so long as the baby was in the mother's womb. Taking care of that lung is a very specialized thing, and can be done only by trained neonatologists. And I'll let Dr. Chandrakumar talk to you in detail about that. This is one thing I'd like to stress in this talk. This is probably the only real surgical emergency that we encounter these days. When I was a trainee, we were told that we had to operate immediately for appendicitis, immediately for diaphragmatic hernia, but all those things have changed now. We know that waiting makes things better in those diseases, but in this one disease, when the intestine twists off, surgery has to be done immediately. And the way you know is if the child vomits yellow or green and gets sick very quickly, you have to rush to the nearest emergency room. And this surgery is this happens because the intestine is twisted on itself, and this surgery is called this disease is called malrotation, and the surgery needs an emergency operation. Now, a lot of patients ask us for this minimally invasive surgery. This is laparoscopic surgery, and we do a lot of it in Child's Trust Hospital. The advantage with the laparoscopic surgery is it is almost scarless. Instead of one big cut, you have 5 or 6 small half millimeter cuts, which blend with the skin as the baby grows. And laparoscopic surgery also reduces the pain and increases the duration, shortens the duration of hospital stay. So this is very popular, but there are certain conditions for which laparoscopy can be done and cannot be done. Now, the indications for laparoscopy are more in adult practice than they are in pediatric practice. And it's very important to know when laparoscopy can be done and cannot be done. Next. Now, this is a baby on whom we are doing laparoscopy for a blocked, the outlet of the stomach is blocked. Next. I'd like to conclude at this point by saying that surgery in children has to be done by trained pediatric surgeons. It is not to be taken lightly, and it has to be performed in a tertiary care hospital because we need the support of an anesthesia team. Although the responsibility for making the child better rests in our hands, the unseen person behind the scene, the God behind the scene, is the anesthesiologist. Going under anesthesia can feel a bit like dying. And taking your child through that experience is the responsibility of the anesthesiologist. And because we have an excellent support team of anesthesiologists, we are able to have good results with our surgical patients. And at this point, I'd like to thank our anesthesiology team for the excellent support they provided me personally for the last 22 years. Thank you.
Thank you, Dr. Priya, for that very informative slide presentation. And I must say, looking at those slides, both you as a surgeon and those who go under your scalpel, both are brave hearts. So next is Dr. N. Chandrakumar, who did his training in pediatrics from Jipmer, Puducherry and AIMS, Delhi. He has vast experience in treating and saving babies with birth weight as small as 550 grams. He successfully took care of the smallest baby with food pipe and windpipe anomaly who managed to survive without complications. He has also published in scientific journals about the rarest complications of COVID-19 neonates. Dr. Chandrakumar will explain the role of the neonatologist in safe surgery, and he will explain how the babies are prepared and taken care of before and after the surgery so that the outcome is optimal and the recovery is easy and fast. Over to you, Doctor.
Thank you, Hindu Wellness Series and Kanchi Kamakoti Child Trust Hospital for this opportunity. So I'm here to make my role clear. What is the role of neonatologist in caring for babies who undergo surgery? So first of all, I think most of the audience would not know who this neonatologist is. Neonatologists are actually trained doctors. We specialize in taking care of babies who are less than a month old. So why these babies, you need a specialist for a baby who is just less than a month old, because they are very vulnerable. They have very high mortality rates. So let us look at what is neonatal mortality or death, because this is the one, this is the most vulnerable age group. The mortality in the newborn period is the highest in the lifetime of an individual. So for every 1,000 babies born, 25 babies die in India. And this number is almost half, 12.5 in our state of Tamil Nadu. The goal is to reach single-digit neonatal mortality rate. As the neonatal mortality reduces, the complications, the conditions which causes neonatal mortality, common conditions such as infections, prematurity, all those things come down. And then what takes a major role is these birth defects or congenital abnormalities. So now at present, congenital abnormalities or birth defects contribute to almost 10% of neonatal mortality. So when we have to achieve single-digit neonatal mortality rate, we need to understand that we have to treat these babies who are born with birth defects and make them survive so that we can reduce our neonatal mortality rate. We can bring it down below 10. So in India, only state which has done this so far is our neighbor Kerala, and we are next in line. And yes, we need to understand that we have to treat this birth defects. We have to take it seriously. So this graph also shows that, as the neonatal mortality rate reduces in a particular state or country, the birth defects, the purple column, you can see here, it keeps increasing. So the contribution by birth defects to neonatal mortality is quite high. So in this slide, you can see like the birth defects, how much proportion of birth defects results in, hospitalization and mortality. So 2% of surgical admission in a tertiary NICU is big for surgical conditions. So in our center, it may be slightly more because it's a referral hospital. 6% of babies are born with a congenital anomaly. 10% of neonatal deaths, as I told earlier, are attributed to congenital anomalies. And we need to understand that burden of congenital anomalies attributed, 94% of the burden due to birth defects is in low and middle income countries. And in our country, India is one of the low and middle income countries. So 94% of the problem due to birth defects happen in these countries. This is the data from Child Trust Hospital. So we had almost 4.8% of babies who were admitted for surgery in 2018, and similar proportion in 2019. In 2020 and 2021, we had more babies admitted for surgeries due to COVID pandemic. The other problems were slightly less. So saving a newborn who needs surgery is really a teamwork. So these, you can see here a picture, a plethora of pictures, which all of you have been exposed to in the previous presentation itself. So a child born without the hole to pass motion, that is anal atresia, a baby with bilious vomiting who is vomiting bile because of block in the intestine, a baby with an intestinal obstruction presenting with the distension of the abdomen, bloated abdomen, a child with both testes which are absent, a child who is having frothing in the mouth due to blocked food pipe or some other respiratory problem. So it is a teamwork which involves a team of neonatologists, pediatric surgeon, and pediatric anesthetist. We three form the core of the unit, but nonetheless, we need the help of cardiologists, sometimes geneticists, nephrologist, neurosurgeon, and other specialists as required. What is our role as a neonatologist in taking care of these babies? We first diagnose the condition, that is, identify the condition. The pediatric surgeon, along with us, pediatric surgeons are always there to diagnose the conditions. So the diagnosis of such condition, diagnosis means you identify the disease per se. So it may be based on antenatal scans or based on clinical suspicion by looking at the baby. Then we do a detailed laboratory work, which I will explain you in detail later. And then we stabilize the baby before surgery. And then we take care of the baby after surgery. And then we follow up the babies. This is what is our role. So we have to play a big role before surgery, after surgery, and then as the baby grows up, we need to take care of them as well. So how do we diagnose or confirm the diagnosis? So before birth, by antenatal scans, so we can identify most of the major malformations by doing an antenatal ultrasound. That is why we insist on getting antenatal ultrasounds. At least, it is must to have an antenatal ultrasound at around 18 to 20 weeks, otherwise called as anomaly scan at 18 to 20 weeks of pregnancy to identify birth defects. Most of the birth defects can be identified at this stage, including some major problems in heart. So after the baby is born, we do a detailed examination, and during this detailed examination, most of the anomalies can be found out. For example, a baby with absent testis, absent anus, or a baby with a diaphragmatic hernia, or abnormal umbilicus, abnormal head, so cleft lip, cleft palate, all these things are identified at birth. Some conditions may not be identifiable at birth, and the baby may present later with some symptoms. It could be breathing difficulty due to problem in lung, problem in the windpipe. It may be due to problem in food pipe as well. So it may be a baby may present with abnormal color, that is, baby may be bluish. Baby may have abnormal facial features, abnormal organs, extremities. So baby may present with distended tummy. Baby may not pass stools after birth, and there are so many other conditions, other symptoms by which a baby can present. So when the baby presents with such symptoms, we do a detailed clinical examination and then arrive at a possible diagnosis. The workup and evaluation again is a teamwork. It is not only the role of neonatologists. We have to involve cardiologists. We have to involve radiologists. We have to involve pediatric surgeon. All of us sit together and decide like what is the likely diagnosis and what tests need to be done to arrive at a diagnosis, so that whether the child's suitability for surgery can be decided, timing of surgery, whether it should be done immediately or later, or in single step or multiple step has to be decided. The special care which is required post-surgery will be planned, and duration of likely hospital stay and the required counseling will be done to the parents. So the evaluation may include simple tests like X-ray. Here you can see X-rays being done with a special dye and all, or it may involve diagnostic scans, bedside scans, or scans in the radiologist room. Advanced testing may include other CT, MRI, radionuclide imaging to diagnose one of the conditions which Dr. Priya had elaborated upon, that is extrahepatic biliary atresia, where bile ducts do not form. And sometimes it may even require biopsy, that is tissue diagnosis. You take a small piece of tissue from the organ and then put it under the microscope to see what disease it is, and then you go in for the definitive treatment. So some babies may even need advanced genetic studies, especially in baby with birth defects. We do this so that we understand what kind of system, what kind of prognosis this baby. Prognosis means outcome this baby has, and whether we have to actively treat these babies for a one single defect, or it is a multi-system involvement wherein the overall outcome of the baby is going to be questionable. So before surgery, we stabilize the baby. We treat, if at all, if the babies have infection, we treat them. Some of these babies with the intestinal complications may be dehydrated. That is, because of repeated vomiting, they are drained of water from their body, salt from their body. So we have to dehydrate, we have to rehydrate them. We have to take care of their nutrition. We have to, if the lungs are infected, we may have to put the baby on ventilation and stabilize them before putting the baby under anesthesia and knife of the surgeon. So after surgery, we have to take care of the baby. Here you can see a baby being cared with so much of paraphernalia. Baby himself is very small, 2.5 or 3 kilos, but the paraphernalia required to take care of the babies are so many. So this is one of the baby who was born with a defect in his food pipe, where the foot pipe was disrupted, and the lower end of the foot pipe joined the windpipe. So this baby was successfully operated, ventilated in our unit, and he was discharged after a hospital stay of 2 weeks, and he went home without any long-term complications. So this involves ventilator care, maintaining vital functions of the heart and kidney, because after anesthesia, babies can have fall in blood pressure or reduced urine output. So we need to follow all these things. We take care of fluids and nutrition. And of course, these babies are prone for infections, and we need to take care of control infection as well as treat it. So after surgery management also includes proper surgical wound care. So our nurses are experts in this. They have handled babies in and out every day, in and out, such babies. Here you can see a baby operated for intestinal malrotation with a loop of intestine kind of popping out. So even these babies are being cared in our unit, and then we provide very good outcomes to such babies. So after surgery management also includes providing comfort to the baby. So we need to provide, these babies are in distress, they are in a lot of pain. So we have to provide them comfort care. So what we do is, provide this something called as nesting, so that they will have the feel that they are being always cuddled. They are always the warmth and the cuddling, which they feel, when they are with the mother, they feel in our NICU as well. So we provide what is called as developmentally supportive care. We switch off the light, we keep the light and noise to the minimum, so that these babies, do not have, can sleep peacefully and then recover well from their illness. Feeding and nutrition forms the core of newborn care. So when the babies are fed well, they fight infections and they grow well, and they can easily go home quickly. So our nurses take care in utmost asepsis in preparation of feeds for these children. So these babies, once they are ready, they are initially fed by tube feeding, and then we do paladay feeding. and then improve their nutrition and discharge them home. So in a nutshell, 4 to 5% of admissions in neonatal ICU is for surgical problems. It could be an emergency in newborn. Surgery is most often safe, even in smallest of the babies. And saving a newborn who requires surgery is a teamwork. It's the main team players include surgeon, anesthetist, and neonatologist, and each one of us have our role carved out. Thank you.
Thank you, Dr. Chandrakumar, for that very reassuring and extensive talk. Now we'll have Dr. Ramesh. Dr. Ramesh has been practicing exclusive pediatric anesthesia for the last 36 years. He's credited among the first to become a specialized pediatric anesthetist in the country. He has represented India for the Children of the World Anaesthesia Foundation. His primary objective is teaching and training and to ensure surgeries done on children, they go safe and are pain-free. He will speak on the hospital's focus, the role and challenges of the pediatric anesthetists in handling children of all age groups. Over to you, Dr. Ramesh.
Thank you, Dr. Soma Basu. It's really very nice of you to introduce the hospital and the panelists, and it's really a pleasure to be a part of this particular panel along with Dr. Priya and Dr. Chandrakumar, and of course the moderator of Soma Basu. We are all grateful to the Hindu for publishing this, because it is more like an education for the people that how surgery can be safe. So I just want to talk about safe surgery and anesthesia for children. My disclosure is that first disclosure is that I'll be blowing my own trumpet in this. I've been told by one of the pediatric surgeons, if you don't blow your trumpet, who else will blow your trumpet? So I have to blow my own trumpet for another 15 minutes. I am from this place, Chennai, and the Chennai and Child Trust Hospital is like this, and we are in the second floor. Here we are all the operating complex in the second floor. The roadmap I will talk about 15 minutes about the anesthesia, because I am sure I just want to tell about and pediatric anesthesia practice, how we put to sleep, the pain free after surgery, a couple of memorable cases and concluding remarks. Just the anesthesia. How does the public know about anesthesia? Many of the public thinks that anesthesia is not a doctor. So they are really very difficult to exactly, now the things are different, people are understanding whom they are. But sorry to say this, the patients know anything whatsoever about anesthesia is through conversation of friends and fellow patients and the media about the adverse outcomes than the good things. That's what happening in the public, that's what they know. If you see any of the papers or any of the media, it proves the anesthesia overdose kills the baby. I don't know how the overdose will kill the baby. It's very difficult as a qualified anesthesiologist. In a Tamil paper, they will written, Mayaka doctor, Adhiga Mayaka Marandu Koduthu Vittara. See, we are all been trained, and it's really very sad. So it's like, for example, so many flights go every day, but this one, a mishap pattern is all in the newspaper. Same thing happens here. In anesthesia as well. So I compare the anesthesia with the air travel. So air travel is compared to anesthesia. In the plane we have a cockpit, and cockpit is managed by the pilots. And whereas in the operating room you have anesthesia workstation, and this workstation is managed by the anesthesiologist. The only difference is the pilot manages about 300 people at a time, and we manage one patient at a time. So it's comparing, when you check in, it is similar to pre-operative assessment. We check the child whether it's fit enough, you want any other test. So we make sure the child is optimum for surgery. If the surgeon feels he needs surgery, we don't operate tomorrow. We want to make sure the child is all right before you take it up. The second is takeoff. The takeoff means you have to put the child to sleep. I'll show you in the video how we are putting the sleep. There are two ways. People who put what is called as the vein, we call it a narambu in Tamil. Narambla porunga illati vande mookla vaingonvaanga. So what you do is put the sleep to there are some places where even from the narambu we make small magical cream so that when you are putting it there is no pain. So I think we now use a takeoff. Then cruise. It may take from half an hour to Coimbatore or 24 hours to probably Chicago or Boston. But what I always tell the person is, there can be a minor surgery, but there is no minor anesthesia. The risks are the same whether you are traveling from here to Coimbatore or you are traveling from here to Chicago. The risks are the same because the steps are the same. So during the anesthesia, I have to maintain during the surgery, and then we have to land. See, we have to cruise, then we have to land. That means after surgery, I have to bring back the child to the normal things. I think that's more important. Finally, we have to real customs and immigrations, then the child should be recovered fully, normally, without the pain. As you see here, in every step, we have to be careful, as been done in the pilot during the air travel. Having said that, I'll come to what is pediatric anesthesia practice. Has been very clearly told, what are the unique challenges? Children are not small adults. Infants are not small children. And just born, what we call as newborn and newborn, are not small infants. So everything is a different. Adult means, okay, 54 kilos, after that is an adult. We treat from 450 grams up to 100 kilos. In 1912, Crichton has written his book that any neonatal operation lasting more than 15 minutes is destined to failure. So you cannot operate. But what's happening now in 2022? About 2.2 kilo baby, huge tumor, in Tamil you call katti, so mula katti, that's so the huge tumor, about 6 hours of surgery with the microscope, the tumor is removed and the child is all right. So that is so much of advancement in the training, and the equipment has come in the last probably about 3 to 4 decades. More important, one is anesthetic a child, one is anesthetic the entire family. If a child has a problem for surgery, the parent will come, the grandparent will come, their uncle will come. So not only one child, and we should not shout at them, they are all anxious, that's why they come with a child. We just have to console them that this is very important. The safety of a children's anesthesia depends upon the 3 things: the person, the place and the patient. The person, as you see that 1.4 billion is total India's population approximately. 40% of the India's population is less than 18 years, about 500 millions. And if you see a statistics about 10 years ago, it's more or less the same. Any type of surgery, what Priya has told, general surgery or urology, brain surgery, heart surgery, eye surgery, approximately 30% of them will be children. So that means 30% of the anesthesiologist should be trained in anesthetic children, but it is not so. So now the question comes, is there a need for formal recognition of pediatric anesthetist? I think it is unquestionably yes, you need a pediatric anesthetist, because there is no routine case and the outcome is improved in higher risk situations, it is more efficient. Parents are very happy when they say that I am only a pediatric anesthetist, I will take care of the child. But is it practical or possible in India? Because it is not possible and practical, because there are manpower issues, where to train. Very few centers have training for pediatric anesthetists. Definition is not clear. Who is going to be a pediatric anesthetist? There is, every case is done in every hospital. Why should you have a pediatric anesthetist? The benefit is uncertain. But I want to tell you, the people and the public, not because that the aim of a specialty of pediatric anesthesia is set a standard and not to create a monopoly. That's very important. Having said about the person how he is to train, I will come to the place. When the child is brought by the mother and mother is given to an anesthesiologist, the parents' last words repeatedly are, please take care of my baby. I think that's a very, very affectionate thing, and I am very scared. Even about 35 years after anesthesia, when they tell me, I am really worried and I want to give the child back after surgery in the same condition what I have taken from the mother. It's a big responsible. For that, you need a very good place. This is not really propagating on this. You need everything what is necessary for the child. This is the surgery. As soon as the child, we have an oximeter. I think the COVID made the public to understand what the oximeter is, what the saturation is. So it's easy for me to tell you, just put the pulse oximeter, but you can see this is an adult pulse oximeter. There are called a pediatric, which is smaller. There's one in neonate, which is much smaller. So you need all the sizes for the different sizes. Put the ECG and the blood pressure, and this is the machine which maintains everything. And more important, during the surgery, the anesthesiologist should be by the side the whole surgery. Of all the things which has been monitored other than the blood pressure and the pulse and the saturation, very important, because in the child you have to put the AC which is about 24 degrees, the child will, hypothermia will come, the temperature will go down. When the temperature goes down, the child will not recover. So we need an operating room which you can set your temperature, initially with temperature high, later on your temperature has to be low, and during the procedure there is a special equipment needed to warm the child. And important is you must maintain the temperature from the beginning till the end. This should never be neglected. And that is here many of those places where we operate and then we put it in the ward. But it's important that you need at least 3 or 4 beds in the recovery room, because where we see that the child is pain free, the child is all right, the feeding is all right, and sometimes we allow the parents also come to the recovery room so that they can be involved in the recovery of the child. Coming to the patient, that children comes in all shapes and sizes. Adult may be one size, maybe a little different, maybe 50 kilo, 80 kilo, that's okay. We operate from 1 kilo baby, even less than that, now 600 grams baby to 100 kilos. It's from just born up to 18 years. It's a wide variety, so we should do everything. The more important is the assessment. That is, when the child surgeon says the child for surgery, it comes to us, it is our duty to assess the child. I have small cabinets, it's a very small cabinet, which is in the small cabinet I have kept all the books which I don't read all the time, but I have got all the shields which is there here just to encourage. Many of the parents have come and told the child, you see this doctor has so many awards, so many books, so they are really encouraged, and I am not putting us for the show off, but it is want to give this one for them to say that you are in the safe hands. Parents are very happy, children are very happy. How do we put the child to sleep? We can put by a gas, or you put a magic cream and then put in a cannula or a needle, then you can put the sleep. I just want to tell you, sometimes the parents ask that they want to come during the surgery, and we explain to them everything, and I just want to tell you how we do that. This is brought the child like this, and we get a gown for that. We have sometimes a special room called the induction room. I keep some song, keep on singing some song, whatever I like. The only song I know is Ek, Do, Teen, Char, Panch. The child thinks that I am counting and the child goes to sleep. This is a very important time where parents knows and everything has to be explained. And just want to know, we never stopped working during COVID, and all of us, because many of the surgeries in many hospitals are refused as a child, and we have to do at least about 5 to 6 surgeries per day, and we worked with all the time. That is my colleagues, and we have done a lot of emergencies during COVID. You can imagine a child operating with all this one, how difficult it would have been. Pain free after surgery. I think everybody is thinking of injection, and putting a drug into the NS is a very normal. All the drugs which is the injections are coming with this, paracetamol is coming, bronchodilator is coming, diclofenac is coming, so you can all pain relief can be done without the injection. And we have got a special machine where continuously we made drugs are given, so that we don't give the toxic dose, not less dose, correct dose. More important, I am really proud, and the only time that there's a big incision like this, what Priya has got a big tumor, and mother came to me and gave a thank you letter. This is the only time a mother has given me a thank you letter for 35 years. What she told is that you were concerned and made our science treatment in the hospital and your care that much easier. Many thanks to you, magic doctor. Our son doesn't realize it, but you did a really an extremely painful experience. They told me, magic doctor, because you put an epidural like this, and so that there's no pain here. You inject the drug here, and there's no pain here. So that's how it is. Couple of memorable cases. That's a child that aspirated, that is the some when they are in a small baby or the 2 years old, they are given some fruit, the seed is been aspirated, they are given to different hospitals, that is CT scan, when they came it's almost the child was dying. And this is the this is the trachea main breathing tube, and the whole thing is obstructed and saturation only 30-40. Didn't do any test, and we brought to the hospital, and immediately I rushed it as a life saving. As you can see here, we didn't have time to put the glove because that's how emergency is like this, and we removed like this. There's a big swollen seed was removed, and this is what it is removed, and the child is okay. So it's important that anesthesiologists have a lot of presence of mind. This case 2 is the reported in the journal, which is the 1.1 to 1.1 kilo, the lowest one, with a lot of problems, with a breathing tube and the foot pipe was connected, and this was what he was Chandrakumar was telling about. And the child is now, I saw about 4 months, the child was like this. And this was published in Hindu as well. Baby undergoes life-saving procedure at City Hospital, the lowest baby, which is okay. Finally, I will conclude with some remarks. Sorry to put this picture. This was the situation about 60 years ago. Because they think that small baby cannot take up anesthesia, the risk is high. So this is what is called as the Christ bar. They tie both the legs, both the arms, and then they give some local injection, they will operate. I am not telling any find fault with anybody, but I want to pray at least from 2022, no one should do like this. It's not really like, because I want to say anesthesia is very, very safe, no problem at all. Finally, what did Arjuna really ask Krishna? What did Arjuna really ask Krishna? Oh my Lord, please give me the strength to handle the challenges in pediatric anesthesia. And give an hand technically to tackle the inland, to tackle the infants and small children, and I need a brain to use this particular hand. I think it's very important that to make the safe anesthetist, I think it's very important that training, teaching and skills, knowledge and affectionate with the parents and the child is a very, very important. Thank you very much.
Thank you, Dr. Ramesh. I think all the 3 presentations were really wonderful, extensive and informative. So we have very little time left for questions, but I'll try to squeeze in. Mr. Ravi, he's specifically asking, because the last presentation has been on anesthesia. So he wants to know 2 things. One is how to deal with the baby after the anesthesia wears off. And is there any type of procedure that can be done just by giving inhalation anesthesia?
Okay, I think it's a very important thing. That is that's what I told is air travel. This one, whether you have to land, then you have to come out of that. Similarly, when you give a minor anesthesia surgery, also you give anesthesia. After anesthesia, we have to wait in the operating room till the child is okay, and every blood pressure is okay, looking around, conscious, oxygen, everything is okay. We have to accompany the child to the recovery room and make sure the child is pain free, and then everything is all right, then you have to do the next case. The other question they ask is what they call inhalation anesthesia is a gas, just putting the gas without putting a line. I think it is not really very, very safe. You have to have an IV line, or what is called narambu, so that any drugs emergency can be given through this. I think by and large only with this mask or a gas surgery, I think it is not advisable to do that.
Right. Dr. Priya, since you were mentioning about trainees and assistants, like Mr. Varun wants to know that every surgeon does have a learning phase. So what would your message be to the new trainees and new consultants handling pediatric surgery?
So they have a huge break-in period. The training program in India is long. our trainees train for almost 6 years in pediatric surgery. And even after that, the training is not finished. Whenever they need help, they need to ask for help, because it's a huge responsibility. And the initial period of your career is when reputations are, it's a make and break time for reputations. So they need to get help whenever they can, whenever they need it, they have to ask. And the other most important thing is they have to utilize their training period adequately. The 6 years of training period seems very long, but at the end of those 6 years, some of them have told me they wish they had another 6 years, because it's just not enough to learn all the aspects of pediatric surgery. We operate on the entire body except for brain, bone, and heart. So they have to utilize their training period, study and see as much surgery and assist in as much surgery as possible during the training period itself.
So what somebody wants to know, what all complications have you encountered in your surgical career of handling any terminal cases? Like, how have you handled them?
All surgeons would have handled death. You can't become a surgeon and stay a surgeon for more than 20 years if you've not handled death. I had a similar situation myself, with a child with liver cancer. And this was a life-altering experience. This happened early in my career. I had a senior surgeon operating with me, and this child was 1 year old, and he had extensive liver cancer. 20 years ago, we did not have the equipment we have now, which has made liver surgery really safe. And we were operating, and we lost this baby because of various reasons, one of which was extensive blood loss from the tumor. And what I learned from that particular patient was, it was a humbling experience. And what I learned from that particular patient was that the surgery in children, if it leads to loss, that loss is felt personally by the surgeon. It was as if I had lost a child of my own. And to this day, I feel that pain. And I think in a way, it is this human aspect of us that helps, that communicates with parents, and they were able to empathize with me, and I was able to empathize with them. And I just felt that they didn't blame me enough. It was the disease, it was a cancer, it was a bad tumor. But I just felt that the mother was exceedingly kind to me. And later on, looking back after all these years, I realized that the reason she was kind to me was she thought I was suffering enough already.
Mm-hmm. Dr. Chandrakumar, of course, babies, they can't communicate if they are in any kind of discomfort, say post-surgery. So somebody wants to know, like, what kind of pain relief babies are usually given after surgery? Because everything seems to be having an after effect. Even for adults, we'll say that, these painkillers have an after effect. So for babies, how is that decided?
So newborns, we follow something called pharmacologic as well as non-pharmacologic measures. Like non-pharmacologic means, like, we need to give that comfort to the baby. So in my presentation, I told you, we provide nesting, comfort care, minimize noise. All those things are called, like, you soothe the baby without giving any medicines. And then medical measures also we do take, because those things may not completely relieve them of pain. So we use drugs like, the commonly used paracetamol. Now it is available as injections that we may give. And then we may use other intravenous drugs also, stronger medicines, which may sometimes cause, respiratory depression. That is, these babies may not regularly breathe. If these drugs are started, then they may require some respiratory support when these medicines are started. But under close monitoring, we provide them pain relief so that these babies completely, comfortably recover from the effect of surgery.
And also, Mr. Lakshminarayan wants to know that, how common is kind of a turbulent kind of a situation post-surgery? During surgery, of course, you would encounter different difficulties and challenges, and you will overcome. But post-surgery, I mean, what are the kind of turbulence you encounter in the?
It is not always safe landing. Most of the time, it is safe landing. Yes, sometimes it is turbulent. It depends on what condition we are treating. For example, if a child goes in for a surgery like a diaphragmatic hernia, Dr. Priya explained in her presentation, wherein there is a hole in the diaphragm, that is the muscle which separates the chest and the abdomen. So part of the intestines go into the chest and the lungs are very small. So such cases may be very tough sometimes. Okay, so because the babies have very small lungs, the lungs pressures are very high, so it is very difficult to ventilate these babies and get them out of the ventilator. So it depends on what condition we are dealing with. Similarly, for gut conditions, operations on the intestines, sometimes baby may be left with only very short bowel. So we have almost a meter of small intestine, but some babies may be left with only few centimeter of intestine. The rest had to be removed because they were diseased. So these babies, feeding them will be very difficult. Whatever you give, the same milk may come out. So these babies are very challenging. So in the course of hospital stay, they may, face a lot of complications, including infections. But we need to take care of them carefully. I mean, they may spend a lot of time in the unit before getting discharged.
Dr. Ramesh, are there any long-term effects of anesthesia on the babies, and how do parents have to deal with the baby after the anesthesia starts wearing off?
Okay. Actually, let me take Mr. Lakshminarayan for a second, because the questions will have a turbulence. I always tell, as an anesthesiologist, is the hours of boredom and moments of terror. The same thing is the pilot also, like where you are turbulence, we will have, we will be bored all the time. Suddenly the child will become bad, we have to deal with it. I think that's turbulence happens, what's happening in the plane happens in the surgery also. I think this is a very interesting question. This one, I think somebody who's aware is asking this particular question, because I think in the lot of things is coming in the social media, in the papers, and everybody, that if you give anesthesia for the child and later on the child's intelligence or something is affected, and it's a very, especially when the child is from IT industry and they come and they ask me, it's a very, very difficult questions. About 10 years ago, it became very, very, very prominent that you should not give anesthesia for less than 3 years, and it has come in the paper, and I thought I will lose the job as a pediatric anesthetist, because if no surgery less than 3 years, then I don't have a job. So I think that was a big anxious moment at that particular time. But there are a lot of studies, but lossless studies, I'll tell you, is in the animals. So they're comparing the apples and the oranges. So what's happening in the animals cannot be interpolated into the child. So I think it has been proved very clearly that many they asked, if we give anesthesia, will there be any problem? I cannot say there will not be problem. I can't say that, because a small child may not have any problem at all long term, because very clearly told there are 3-4 studies. I don't want to really tell. It has been probably so many studies from UK, from US, from Netherlands, Holland. All the people have come with a particular conclusion that anesthesia can be safely given to the child less than 3 years without any adverse effects. Very clearly it has been proved that, because one small study I want to tell, the person was asked, there are twins, one underwent surgery, one did not go underwent surgery, and they compared after 5 to 6 years their intelligence, their whatever their how they are able to write, how they coordinate, all these things they found they are equal. So I think the anesthesia is not really affecting the long term effects. I can be very clear to the parents, if it is needed, please, I think it has to be done under anesthesia. Don't hold the leg and the hands and do the surgery. It is not advisable.
Dr. Priya, when adults go under the scalpel, they're always worried about the scar that it leaves behind. So with children, do you face any similar things, or children heal better and faster and the scars go away?
Children heal better and faster, but when the scars grow with the child, so as the child becomes bigger, the scar also grows. And that is a concern. And that's why we opt for minimally invasive surgery in many cases. And parents themselves are very aware of it, and they ask for minimally invasive surgery, and we suggest it even if they don't ask for it.
Right. Dr. Chandrakumar, how long you love to keep the kids in the hospital once they have recovered?
So we do not want to keep the kids if there is no indication to keep the babies inside an ICU, because any hospital setting is kind of will may cause infections in baby. So we send them home as soon as they are ready, but it depends on their condition. So, for example, the baby who was reported for this tracheoesophageal fistula, food and windpipe abnormality, which was repaired and got published in Hindu, that baby had to stay for almost 3 months in an ICU before going home. Okay. So these smaller babies who are born with weight of 600, 700 grams, they may stay for almost 3 to 4 months before they go home.
Somebody is asking, can we safely use Dexmed in a child? And if yes, what's the youngest age it can be safely used?
I think this is a very, very technical question,
Yeah,
and this is a very, very technical question, and it's probably definitely by an anesthesiologist. I think it's a very technical question. I don't want to answer, because Dexmed is safe if you can use it safely with the safe dosage, with safe but Dexmed can be used, but you should be very safely used within the dose limits, because it's a very, very technical question. Latest drug which has come, I don't want to tell in the public, and there are yes and no.
Okay,
So probably he has to write mail to Dr. Ramesh, so that.
Yeah, I think that the participants can shoot off their questions.
Yeah.
So one final winding up question, because Dr. Priya had initially in her presentation mentioned about, people should understand that children should be taken to the pediatrics and trained pediatricians, and also to a tertiary hospital. So how do you amplify this message? How do you kind of increase this awareness?
I think you play a very important role in that. The press plays a very important role in that. And social media plays a very important role in that. And we ourselves have a responsibility to tell, at every meeting we go, I make it a point to say this, whether it's a social meeting or a medical meeting, I make it a point to say this. It's really by word of mouth that this message has to get across. And word of mouth, the newspapers have a bigger reach than we do. The media has a bigger reach than we do. This is the only way to get this message across, a very simple message. If I had an illness that needed treatment, I would not go to a pediatrician. So why do I expect my child to be taken to an adult doctor? That's a very simple question. It applies across the board to all pediatric diseases. If every parent asks himself that question, they will look for a specialist, a pediatric specialist, and take their child to a specialist.
Right. So thank you, doctors, for giving us your valuable time for this webinar, and all the participants who joined in. And do send in your questions if you have any remaining to the doctors you specifically want to get the answers from. So thank you from all of us.
Thank you.
Thank you so much.
Thank you.
Thank you.